Okay, everybody, so now we are going to speak about the tumor suppressor gene. It's a really important topic, and it goes something like this. First of all, I would like to show you what is a tumor suppressor gene. What does it mean? I researched some photos before the class, and it goes something like this. Guys, there is something called the cell cycle. Without understanding what is the cell cycle, there is no point of trying to understand what is the tumor suppressor gene. So let's speak first of all about the cell cycle, and then we can speak about the tumor suppressor genes. So speaking about the cell cycle, here it is. So normally your cells that are growing and proliferate, normally most of your cells are going here. Okay? And when they go there, they are resting. They are not dividing at G0 phase. And can someone tell me which cell cannot exit G0 phase? It cannot exit. It's always in G0 phase. Cardiac cell, excellent. Skeletal muscle cell and neurons. Excellent, excellent, excellent. Okay. So these cells are stuck in G0 phase. They never exited, they are always inside of it. But if we say a liver cell is also in G0 phase. It's resting. But if needed, it can go from G0 phase to G1 phase. Yeah? And during G1 phase, what happens? Duplication of the cellular content, which will be utilized for the process of DNA synthesis. For example, you will be needing a nucleic acid. You will be needing, for the division process, you will need some proteins. So all of the cellular content you are making during the G1 phase. Okay, so you have moved from G1 phase to the S phase, which is here. So during S phase, you have S for synthesis of DNA. So you have synthesis of DNA. So initially you had like a, like one cell, and now you made more DNA. After making this more DNA, as you can see, now you have two strands of DNA. What you need to make sure of? You need to make sure that you did it correctly, okay? Double check repair. That happens in the G2 phase. You need to make sure that you did this process 100% correct. Yep. And if that process, after you make sure it has been correct, you need to divide the cell. So you divide the cell into two other new cells. And then these cells will go another time in the cell cycle to divide one more time, and one more time, and one more time, and one more time, and one more time. Well, who controls all of this? Who controls the movement from one area of the cell cycle to another area? The police officer, as a person sent on the chat, and he's correct. So the police officer is this guy. Well, this is one of the police officers. Actually, for the USMLE, they are not asking you about all of them, but for the sake of the step one, you have these. So the retinoblastoma gene and the B55, they modulate the G1 restriction point, which is the point between G1 and S. Think about it, guys. These are like particles that are inhibiting the movement through the cell cycle. They are reducing it. So are they a tumor suppressor gene or tumor oncogene? They are suppressing it, so they are a tumor suppressor gene. Excellent. So when will a patient get cancer? When these are hyperactive or when they are inactive? Inactive. So notice, when we spoke about the proto-oncogenes, the oncogenes, it was a gain of function mutation. Now it's a loss of function mutation. So proto-oncogene, the pathology is gain of function mutation. Tumor suppressor gene, the pathology is loss of function mutation. Okay? So There is loss of function mutation if this RB or B55 are not working, which enhance the movement through the cell cycle, which can precipitate the patient to get cancer. Okay, so now we can speak a little bit more comfortably about the cell cycle. About the tumor suppressor genes. Come on. Yes, tumor suppressor gene. So they write, it's a loss of function, a mutation, which increases the cancer risk. So both two alleles of the tumor suppressor gene must be lost. We call it the two-hit hypothesis. I will explain it in a sec. So two alleles of the tumor suppressor gene must be lost for expression of the disease. For example, you know, some patient, they tell you, oh yeah, her father had, for example, her mother had breast cancer, her grandmother had breast cancer, and now she is afraid of having breast cancer. Why breast cancer is in their family? She has the gene for it, which means if you have two alleles, okay, the lady has two alleles. One allele has the mutation. The other allele is healthy. For the tumor suppressor gene is different from the tumor oncogene. The oncogene, it was enough to have one mutated allele. But in tumor suppressor gene, you must have both of them mutated. So if she only has one mutated, she will not get cancer until there is the second hit, which is the other gene or allele gets mutated. If the other allele gets mutated, she gets the cancer. And we call that two-hit hypothesis. Also this Knudsen's two-hit hypothesis, okay? So most of the time, they inherit one dysfunctional gene, and during their life, due to some other risk factor, they get the second mutation. So the first one is the ABC. So some of these are important to know what they mean. For example, adenomatosis polyposis coli. Okay, adenomatosis polyposis coli. Well, that one lead to colorectal cancer, and it's associated with familial adenomatosis polyposis. Okay, so it works in something called the beta-catenin WNT pathway. So let me show you this. So the catenine WNT pathway is a long pathway, actually, really complicated pathway. They don't want you to memorize it because actually, like when I try to read about it, it's really complicated. It has so many particles inside of it. Yep, it's something crazy like this, but you don't have to know the whole thing. What you need to know is as simple as this. When the beta-catenin pathway, this guy has a what? A loss of function mutation. It's not functional. The cell polarity and cell development will be uncontrolled. Okay? So you will not be able to control normal proliferation. So your cell start to hyper proliferate. Okay? If it's hyper proliferating, that basically lead to the cell to have cancer. Okay? So let's speak about it's a gain of function mutation. Let me tell you something about it. It even manipulates the process of apoptosis. It leads to the apoptosis occurring less. I just hope it's mentioned here. Yes, so you see the beta-catenin and the WNT there. So we call it the catenin WNT pathway. But it has some relationship to apoptosis in which it reduces apoptosis, okay? It reduces the risk of apoptosis. So when, here it is. As you can see in this picture, let me open it up. Your WNT is activating long cascade, which eventually give you the beta-catenin. This beta-catenin target gene activation. So they lead to what? They lead to activation of the beta-catenin, which lead to cell proliferation. Okay? So In case of tumor suppressor gene, where it is, yep, here. The ABC is a negative regulator of this guy, okay? So when he's dysfunctional, this guy will be working more, yes? So the negative regulator, which is the ABC, will not be able to inhibit this guy. So if this guy is not inhibited, he will be working so much. If he works so much, he will have a lot of cell proliferation, which lead to cancer. Okay, let's go back here. So that can lead to colorectal cancer. We have BRCA1 and BRCA2. They are associated with the breast cancer, ovarian cancer, prostate cancer, and pancreatic cancer. Most important is to know about the gynecological tumors. The next one is the Cdkn 2A, and again, it's a lot of memorization. It is one of the police officers, and it blocks the conversion of G1 to S phase by making a protein called B16. And you know now what is a G1 to S phase. It was in the cell cycle, if you remember. And it can lead to many cancers like lung cancer and melanoma. The next one is the DCC, which stands to deleted and colorectal cancer. Well, basically tumor suppressor gene. It cannot be better name. So it can lead to colorectal cancer. The deleted in pancreatic cancer, the DBC4, or also called SMAD, it can lead to pancreatic cancer and colorectal cancer. Most importantly, pancreatic cancer. I never saw a question about this one actually. MEN1, it makes menin. You are like, wait, no, you are wrong. It was the red. Red was for men to A and men to B. Menin is for men1, okay? So this is actually important. Red is an oncogene, so it's a gain of function and mutation, leading to men to A and men to B. While menin is a tumor suppressor gene, and it was a loss of function mutation, leading to multiple endocrine neoplasia type 1. Not type 2A, not type 2A, not type 2B. Okay, now there is neurofibromatosis type 1, and it basically makes a tumor suppressor gene called neurofibromin, which is a RAS GT-base activating protein. And this RAS, when it's hyperactive, it leads to what? It leads to cancer, okay? So neurofibromatosis type 1, do you remember what optic problem people with neurofibromatosis have? Something called optic glioma, okay? So optic glioma they have in their eyes. See it? It's basically a glioma of the optic nerve. Yep. Okay, and it makes them blind. We'll speak about it in neurocontinuous disorder in the CNS. So neurofibromatosis type 2 is in the Merlin tumor suppressor gene, also called the schwannomin protein, in which it's associated with neurofibromatosis type 2. The next one is the BTEN, negative regulator of another pathway. It's, guys, this is exactly like the same idea, like the beta-catenine WNT pathway, but this pathway is named differently, okay? So it's basically, if you Google it, you will see that this pathway looks similar to it, like it has more survival from apoptosis, all of this stuff, but it's related to different cancers. That's the thing. So, come on. Okay. Okay, so let's take a look. So as you can see, guys, here, there is, where it is, yep. So this guy, the BI3K, inhibits this whole process, and these are inhibitors. So all of these inhibitors are working to reduce the risk of cancer. So if you inhibit an inhibitor, you have an activation. If you have an activation, you will get cancer. So they are inhibiting the formation of cancer. So if you have a loss of function mutation of these guys, the patient will get cancer. So the next one, so they can lead to breast, prostate, and endometrial cancer according to the name. The little b for prostate, the T for the breast cancer, and the EN for endometrial cancer. The next one is the RB. We spoke about it in the cell cycle. It used to regulate the G1 to the S phase. And it inhibits the elongation factor 2. And it's associated the R for retinoblastoma and the B for bone tumor, which is bone cancer, osteosarcoma. Keep in mind, when you see an osteosarcoma, an easy way to diagnose it is when you look at the picture, focus a little bit at the margins. So at the margins, you will be able to see the sunburst appearance, or even sometimes you can see something called the Codman triangle. Okay, so the Codman triangle or the sunburst appearance. These are highly characteristic of osteosarcoma. Okay, so next. Oh, this is super important one, TB53. TB53, again, we saw it in the cell cycle. It used to regulate, it was the police officer that used to regulate the movement from the G1 phase to the S phase. And basically, this B53 activates a protein called B21, which inhibits the movement from G1 to S phase. If a patient has a cancer, basically this two-hit hypothesis, both of his TB53 has been damaged, destroyed. He will have less B53, less activation of B25, no blockage of the G1 to S phase, hyperproliferation leading to so many cancer. Basically, it's the Sabla syndrome. Sabla syndrome, they call it the Lifromani syndrome, but the idea is like this. The Lifromani syndrome can lead to multiple malignancy at early age, aka Sabla. What is Sabla? S for sarcomas, P for breast, L for leukemia, A for adrenal. They love to ask you about the adrenal one. So the next one, tuberous sclerosis. So tuberous sclerosis 1, tumor suppressor gene, and that was the Hamertine. 2 is for the tuberine. When we do the neurocutaneous diseases in neurology, we will come back to this page. Guys, I want you only to get from today's class, not to memorize all of this. What I really want you to know, just what is a tumor suppressor gene and what is an oncogene. The memorization stuff, you must put this paper somewhere because it's just too much, you know? And if we speak about the small parts, for example, these guys, if we speak about these ones, you will study in neurology. This one in the kidney, we'll study it soon. So each one has its system. You don't have to know all of them today, but just print it and keep it nearby. So the next one is the Vhl Von Hibelinda. It inhibits the hypoxia-inducible factor 1A, and when you have a tumor suppressor gene, the hypoxia-inducible factor will be hyperactive, and when hypoxia-inducible factor is activated, it will lead to angiogenesis. Please make a note about that. So angiogenesis all over your body will lead to formation of angiomas. And that's why in VHL we have angioma. Basically, the VHL gene inhibits the hypoxia-inducible factor 1A. When this guy is not there, you have a lot of hypoxia-inducible factor 1A, which leads to angiogenesis. So you get angiomas. The last tumor is the Wilms tumor. It's an orogenital development transcription factor that can lead to Wilms tumor due to tumor suppressor gene, also called nephroblastoma. I know that this topic is not easy. It's the most difficult page in the whole book. There is 3 pages I told you so far you must print. This is one. In renal we had one. If you remember, it had all of these cells and each function of each cells. And in cardiology we had one as well, which was like this one. Yes? So these are 3 pages you must print. In this book there is around 10 pages like this. When we reach each of these pages, I will tell you to print and keep it nearby. So for today, you must print this one, the one with the tumor oncogene and tumor suppressor gene. Okay, so now we go to something a little bit more calm, something easier. Let's speak about serum tumor markers. Finally, something more fun. So, if we speak about the serum tumor markers, they go something like this. First of all, you never use a marker to diagnose a cancer. You don't. Why? Well, some patient can have it more elevated than other patient, but they do not have cancers. So it's illogical. You will get a lot of false positives. So what you should do is, like, if a person already is diagnosed with cancer and you wanna check if you are treating it correctly, what you can do is to check the markers. If the markers are decreasing, that means that the treatment is working. But if the markers are still high, that means that your treatment is not working. So serum tumor markers. Tumor markers should not be used as a first tool for cancer diagnosis or screening. They may be used to monitor tumor recurrence and response to therapy. But definitive diagnosis is made via a biopsy. You must know this point. I cannot tell you enough about it. They want you to know that biopsy is the only way you can confirm cancer. Some can be associated with non-neoplastic conditions. Okay, yeah, because actually some tumor markers, like for example HCG, it's associated with the pregnancy, yeah? So now it gets kind of cool. The first one is ALB, also called alkaline phosphatase. It's not the same as acid phosphatase. These two are different from each other. So the ALB is secreted from where? It's secreted from two areas in your body. Can someone tell me where do we have ALB secretion from? The biliary system and the bone. Yes, the biliary system and the bone. So metastasis to the bone or the liver will increase the ALB. Badged disease of the bone, it will be skyrocketing. They love to ask about badged disease of the bone. Remember, in badged disease of the bone, there was a lot of osteoclastic activity. Also seminoma. It's a placental form of alkaline phosphatase. Okay, if I have high ALB, it's either the liver or it's the bone. How can I decide between the two? You have to do a more specific test, which is gamma-glutamyl transferase. So exclude hepatic origin by checking the LFTs and GGTs. If the GGTs were positive, that means it's 100% the liver, not the bone. Alpha-fetoprotein. We saw these before. Yes, they are elevated in case of hepatocellular carcinoma of the liver. Also, in case of endodermal sinus tumors, which we'll speak about when we speak about the reproductive system, like yolk sac and mixed germ cell tumor. Also, ataxia telangiectasia and neural tube defects. Can someone give me an example of a neural tube defect? Any example will do it. Anencephaly and spina bifida. These are in neurology. We did not do it yet. Okay, but they are mostly due to, the lady not taking her B9 normally, the folic acid. So they are the alpha-fetoprotein, it's feto from the fetus. So normally made by the fetus, it transitionally elevated during the pregnancy. High levels are associated with the neural tube and abdominal wall defects. The anencephaly, it's true, it can lead to a frog-like face. Yep. Low levels of alpha-fetoprotein are associated with Down. You are like, well, what about Down? What is high in Down? Well, in Down, it's the high that is high. You're like, what? High is high in Down. So that's what is high? It's the HCG, it's high in Down syndrome, and the I is for inhibin B. So these two markers are high in Down syndrome, while the alpha-fetoprotein in all trisomies, not only Down syndrome, will be low. HCG is associated with the pregnancy. Why? Because it's produced by the syncytial trophoblast of the placenta that we'll speak about later. Basically, your placenta have a couple of layers. One of them is called the syncytial trophoblast, which make you a lot of HCG. to maintain continuous production of hormones from your ovaries. So some cancers can lead also to oversecretion of HCGs, especially these cancers that originate from the syncytial trophoblast of the placenta, like hydatidiform mole. Well, what is a hydatidiform mole? Well, it's a long story, but basically it's an empty oocyte that gets fertilized by a sperm. So it's empty, it does not have any DNA. So you only have the DNA of the sperms with an S, yes, because it will be two sperms entering one empty oocyte, for example, or it will be one oocyte that actually has a genome inside of it, but two sperms entering it. So that is 23, 23, 23, so that will make it 69 chromosome inside in hydatidiform mole, if it was complete. If it was partial, it is only two sperms and empty oocyte, that makes it 46. Okay. Also, it can be a choriocarcinoma, which can metastasize to the lung. It can be testicular cancer and mixed germ cell tumor. All of these will be in reproductive. Don't worry about them so much, but remember that the HCG, it's highly associated with basically pregnancy and all of the gynecological tumor, most of the gynecological tumor that are originating from the uterus. Okay, so CA15-3. How do I know that this 15-3 is the one for the breast cancer? I'm sorry for all of the ladies, but the 3 looks like a breast. 3 looks like a breast, so it's a breast cancer. Okay, 15-3 looks like a breast. Okay, what about CA19-9? How do I know that it's a pancreatic cancer? Well, the 9 looks like a pancreas. See, it looks like a pancreas. So 19-9 is the pancreatic adenocarcinoma, because the 9, if you draw it sideways, it looks like a pancreas. Okay? Okay, you're like, okay, what about the C8-125, ovarian cancer? Well, it's 125. I like to imagine it as one ovary here, one ovary there, and this is the uterus in the middle. Okay? So, yeah, that will be ovarian cancer. So again, the 3 and 15-3, the 3 looks like a breast. 19, if you flip the 9, it becomes a pancreas. 125, an ovary here, an ovary there, and the uterus in the middle. Okay, the next tumor is calcitonin. So calcitonin is associated with medullary thyroid carcinoma. Why? Because in that cancer, there is overproduction of calcitonin from the C cells of the thyroid. And it's highly associated with men to A and men to B, because they are the only syndromes that have the medullary thyroid cancer. And guys, let me ask this. In medullary thyroid cancer, is it an oncogene or a tumor suppressor gene? Just write the initials of these pathologies. It's a tumor oncogenes. Excellent. It's an oncogene. Okay, so it's a gain of function mutation or a loss of function mutation? Yep. You are correct, guys. It's a gain of function mutation. Okay, so since it's a gain of function mutation, do you have, come on, man. Do you have to lose one allele or two alleles? One is enough. One is enough. Okay, good. So let's just see. Okay, you are correct. And if we speak about yeah, a tumor suppressor gene, how many you have to get lost? How many should you lose? How many alleles? 2. You must lose both of them. 1 is not enough. Okay. So that's for calcitonin. Now, the CEA, which is the carcinoembryonic antigen. Very non-specific. What does that mean? It means you will never use it as a diagnostic test. Yes? You only use it for monitoring. So it can be used for colorectal cancer, pancreatic cancer. It even has association with gastric, breast, and medullary thyroid cancer. As you can see, it's mostly GI cancer, but it's completely useless for, it's like your ESR. It's not sensitive at all, and you will not use it actually even here, not to get a false positive. You will only use it if someone is getting it treated for some of these cancer to make sure that it did not come back, you know? So let's go back to this one. Okay, so the next one is chromogranin. This is important. It is associated with neuroendocrine tumors, and these will have a lot to speak about in the near future. Okay, LDH, it can be from testicular tumor, ovarian tumor as well. It can be used as an indicator of tumor burden if you have any of it left after you removed it. Neuron-specific annulase, they started adding this one newly to the exam actually. It's also related to the neuroendocrine tumors. But by the way, neuroendocrine tumors mean any tumor that can produce hormones, for example, okay? So, or lead to paraneoplastic syndromes like small cell lung cancer, carcinoid, neuroblastoma, all of these can lead to it. VI BOMA, yes, you are correct, yep. And the last one is BSA. BSA is for a prostate cancer, but if you get a question about a patient who is complaining of problem urinating, and he has like he wakes up 3-4 times at night, and he comes to you complaining, and they ask you what you should do for him, and you have the answer telling you MRI of the pelvis, digital rectal exam, PSA, or what you should do. Which one will you choose? Yep, digital rectal exam. Look guys, on the USMLE, always look for the sheep answers. So the sheep answers tend to be correct. For example, you have a patient with hypertension. They give you lisinopril, thiazide, and lifestyle modification. It's lifestyle modification. Go sheep. Diabetic patient. An anorexic girl. Anorexic girl, she's anorexic, she's not having her period because she's anorexic. And how to treat her? Give her estrogen to get her period back. Blah, 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 blah. The correct answer is to try to convince the patient to eat more so she will gain her periods back. Always think sheep. So BSA is a prostate cancer, prostate-specific antigen. It can be elevated in benign prostatic hyperplasia and prostatitis, which makes it not a really good idea to start diagnosing cancer with, because we know that the prevalence of benign prostatic hyperplasia in the normal population, especially the old people, is super high. So questionable risk-benefit for screening, and I can tell you as of 2021, it's not used for screening anymore. Marker for recurrence after treatment though. So the next one, important immunohistochemical stains. Okay, good. 2 pages will be done with pathology. Okay, important histochemical stains. So, okay, you got a biopsy. After you took this biopsy, you looked at the tumor and it's anaplastic. Remember that anaplastic tumor, that means it does not resemble the original tissue in that area, yeah? Or you look at it and you are not super good at histology, so you cannot know the difference between them, you know? What is what? So what do you do is actually you can do something called immunohistochemical stain, which means you take these cells and then you try to check for an exact particle located inside of it. And if you find that particle, that means it's that tumor, that markers. But it's inside of your specimen, that's the thing. So you take a biopsy, that's your first step. Your next step is to give the stain. Your third step to check if you have that substance or not. So for neuroendocrine cells, like small cell carcinoma of the lung, for example, you can do chromogranin and synaptophysin. So it's for the small cell lung cancer, carcinoid tumor, and even neuroblastoma. What paraneoplastic syndrome is highly associated with neuroblastoma. I show it to you today, guys. What was it? Neuroblastoma can lead to something in the face. Yep, it was the raccoon eyes, exactly. Okay, so the next one is the cytokeratin, which is like on your epithelial cells. Remember, in case of squamous cell carcinoma, if you take a look at squamous cell carcinoma, so squamous cell carcinoma, they have something called the Keratin Barrels. Like inside of the squamous cell carcinoma, there is these little Keratin Barrels. They are not Absolument Body. This is different from each other. So these Keratin Barrels are just pinkish accumulation that are made of keratin. So, okay, and that keratin is always inside of a squamous cell carcinoma. And if you check for cytokeratin and it's positive, that means that this tumor is from epithelial origin. The next one is Dysmin, and it is from muscles, for example, muscle tumor like rhabdomyosarcoma. The GFAB for neuroglia like astrocytoma, Schwann cells, and oligodendrocyte. Be careful about the Schwann cells because they also have the S100. So it can be astrocytoma or glioblastoma. The glioblastoma is this butterfly cancer that you see in movies, like oh, patient was totally normal, but she suddenly got headache in the morning, went to her doctor, and they found out that she has a brain cancer. Oh yeah, that's glioblastoma, the one that happens really quick, kills the patient within 6 months. Okay, so the next one is Neurofilament. Neurofilament is in the neurons, and it's a neuronal tumor that can be also in neuroblastoma. Okay, the BSA, we said about it. It was, but here we mention it as a Immunohistochemical Stain, not a marker. So it can also be used for prostatic epithelium checking, prostate cancer. The next one is the S100. So it's for the neuronal cross cells leading to melanoma, schwannoma, Langerhans cells, histiocytosis. Okay, so the Langerhans cells, you must also know about one more thing about it, that it does have this. It does have one more characteristic on histology, which we call it the tennis rackets. So in histology, it will have something like this, tennis rackets. The moment you see it, it's a Langerhans cell histiocytosis, and it stains for the CD100 positive. Please remember about this, they ask about it a lot. The next one is the TRAP. It's in hairy cell leukemia. It's basically this tartrate resistant acid phosphatase. I'm sorry guys, I'm just reading, but basically this is all memorization, and when we will be doing the other system, we'll come back to it. That's the thing about it. The next one is the vimentin, which is a mesenchymal tissue, fibroblasts, endothelial cells, and macrophages. So it's in sarcomas, because sarcomas are cancer that comes from what? Mesenchymal cells. But also it can be from other tumors like endometrial carcinoma, renal cell carcinoma, or a meningioma. Basically anything with a mesenchyme inside of it. Now we go to something a little bit more interesting. The cancer cells, this is a cancer cell. You decided to give chemotherapy. So you give the chemotherapy for the cancer cells. After giving it this chemotherapy, the cancer cell was like, holy shit, he's using cancer therapy on me? Okay, bring me that that chemotherapy, thank you so much. I'm creating an efflux bomb to get it outside of me, so you will not kill me. You will just be making the patient suffering, but you are not killing the tumor. Yeah? So this is the B glycoprotein. It's basically, the B glycoprotein is an efflux bomb inside of the cell that gets any chemotherapy that you get inside of the cell to the outside of the cell. So yeah, it's really bad. Why? It means that the cancer here is resistant to the chemotherapy. So look what they write. Big glycoprotein, it's an ADP-dependent efflux bump, also known as MDRs, which are multiple drug-resistant protein 1. Classically seen in adrenocortical carcinoma, but also expressed by other tumors. Do not let the adrenocortical carcinoma trick you. It can be by any cancer in the body. It's used to pump out toxins. Oh, really? Toxins? That's good. So the cancer cell is trying to pump out toxins. Wait a second. Which toxins? Chemotherapeutic agent that you gave as a doctor. Okay? So it's one of the mechanisms of decreased responsiveness or resistance to chemotherapy over time. So how you can overcome this? The way to overcome this, remember, are cancer cells motile or immortal? They are immortal. Since they are immortal, there's a trick you can do. Bring a blood culture, okay? Put cancer cells inside of it. They will start proliferating. And then add chemotherapy A, chemotherapy B, and chemotherapy C inside of this culture. And check for the proliferation of the cell. If in culture C there is no proliferation, but A and B has normal proliferation, which chemotherapy are you going to give? A, B, or C? Yes, it's C. So it is used, but it's rarely used right now. Because here is the thing. It has one bad thing. Takes time. Do you have time in cancer patient? Most of the time you don't. But to be fair, it's one of the best. You know? It's actually one of the best, but it's rarely used. It's not cost effective. I'm sorry I keep saying about money, but actually this is true. In the US medical system, it's really expensive to invent a new treatment. So now, most of the time, you think about the cost effective a lot. There's a lot of diseases you can deal with, but you think about the quantity over quality, sadly, in a lot of these diseases. So it's used to pump out toxins, including chemotherapeutic agent. It's one of the mechanisms to decrease responsiveness or resistance of the chemotherapy over time. Okay, the next thing is Absolument Body. We'll keep seeing it, actually, throughout the book. Whenever we read a new page, we will see it again. As you can see, it's laminated concentric spherules with which form of calcification? Dystrophic. They do ask about this. So when we speak about dystrophic calcification, guys, do you have normal blood calcium or a high blood calcium in case of dystrophic calcification? In case of metastatic calcification, you have it high, but in case of dystrophic calcification, it's normal. Okay? So in case of dystrophic calcification, the main idea that you have a tissue that it is destroyed, okay? And it starts becoming calcified. That's it. So tissue is harmed and it's starting to become calcified. So as you can see, dystrophic calcification and the serum calcium is normal. So it just become calcified because the tissue is diseased. Okay. So the next one. Yep. So now we are going to speak about different diseases that have Absolument Body inside of them. So they have the mnemonic. I actually like it, Absolumomas. So you have the papillary carcinoma of the thyroid. We'll see that. Also you have somatostatinoma, adrenal one. Oh, they add this one is new actually here in this book. Okay, good. And meningiomas, you must know. Guys, which hormone lead to overstimulation of the proliferation of a meningioma? What hormone lead to proliferation of meningioma? Which hormone lead the meningioma to hyperproliferate? Actually, it's estrogen. So this is why it's more common in ladies. Okay, what about malignant mesothelioma? What is the substance that can lead the patient to get a mesothelioma? Asbestos, you are correct. Okay, the next one, ovarian serous carcinoma. Remember that these patients, most of the time, they have a concurrent ascites. Prolactinoma, well, it can lead to galactorrhea from the breast, and serous endometrial carcinoma. Okay, so again, a lot of memorization in this chapter. Okay, now you must know why the patient have cachexia. Cachexia, it's when you take a look at that patient and he's really thin. It can happen in case of heart failure, COPD, AIDS, cancer, a lot of diseases. It happens due to two things. In case of cancer, you need to keep in mind about something called the Warburg effect. Does anybody remember what is the Warburg effect? So, yep, Warburg effect. It was a process in which we had overactivation of the anaerobic glycolysis, in which you have hyperconsumption of the glucose. Hyperconsumption of the glucose reduced the amount of glucose inside of your body, which made you really thin. So that was the Warburg effect. Okay, so that's one difficult concept. What else? Other than that, other things that can lead to weight loss, muscle atrophy, and fatigue in chronic diseases, well, cachexia in cancer, for example. Other than the Warburg effect, you also have what? The TNF-alpha, tumor necrosis factor alpha, interferon gamma, interleukin 1, and interleukin 6. These also can lead to cachexia. Okay. So the next topic and the last topic for today will be the paraneoplastic syndrome. We'll be starting to speak about them after the break. It's only one page. It's one of the difficult pages as well, and we'll be done with pathology. So let's take 10 minutes break and be back after the break.